Thanks for asking me to deliver this talk. So it's regarding the use of atherectomy and non-atherectomy techniques. In fact, we can't separate them out. Most of the time, we have to use both strategy, majority of the patients. This is my disclosures. So agenda is to discuss the challenges posed by the severely calcified coronary lesions, review and compare the two strategies, and examine the clinical evidence, and discuss the algorithms, which has been discussed quite extensively by Dr. Zaid, along with the imaging. So as we know, calcified coronary lesions are becoming increasingly common. We encounter them more commonly now. And a significant coronary calcification is in about 1 out of 10 patients, although in the mild and moderate, if we take that into account, so would be even more than that, as discussed by Dr. Zaid. Calcified lesion can be difficult to treat percutaneously due to high failure rate of balloon angioplasty, high risk of complications in terms of coronary perforations, and stent under expansion, and future risk of thrombosis and restenosis. So this is data from the pool analysis of the Horizon AMI and Equity trials, which showed that the more severe calcification is, the worse the prognosis is. The way imaging is important, obviously, for identification of calcification. Dr. Zaid has discussed that in quite detail, but we see them on CT coronary angiogram, and we can measure the score. Coronary angiogram showed tram track appearance. IVUS tells us about the arc of calcification, the depth, and the length, while the OCT also tells us about the thickness of the calcification along with the other information we get. So the treatment modalities, there are two main treatment modalities, the non-atherectomy and the atherectomy strategies. The non-atherectomy strategies include a modified balloon, like cutting balloon, non-compliant balloon, and IVL. The atherectomy strategies at the moment available for us in clinical use are the rotational atherectomy, orbital atherectomy, and laser atherectomy, and we are hoping to have a few more in the future as well. Mechanisms of action for the modified balloon is microfractures and controlled dissections, and the IVL delivers acoustic pressure and creates fracture in the calcified part of the coronary artery. Atherectomy does debulking, ablate the calcium, and disrupt the plaque. This is a comparative slide of use of various techniques. So we can see here that IVL is the easiest one to use with less complication rate. However, in severely calcified lesions and uncrossable lesion, we would be still forced to use the rotational atherectomy as a treatment option. The comparative summary of the both techniques, so non-atherectomy is simplified, less expensive, lower risk of complications, and it's good for mild to moderate calcification. The disadvantage is that the lesion may not be well prepared and there might be still under expansion of the stent. The atherectomy strategy makes it more successful to cross the lesion, modify the lesion, and deliver the stent. However, it's more complex and more costly and involves more time of the procedure, fluoro and contrast use. So imaging assessment, it's been discussed quite extensively, but through imaging, we look at the arc of calcification, the depth of the calcification, the length of the calcification, and thickness of calcification. And various scoring system has been in place and been developed further to identify severely calcified lesion and to use the devices accordingly. The evidence for the plaque modification, so far, none of the studies have shown long-term mortality and morbidity benefit. The OCT study comparing the orbital atherectomy and rotational atherectomy showed that orbital atherectomy might be better in preparation of the calcified lesion and might help deliver the stent well with good expansion. As mentioned, lots of studies are coming through, and previous studies and meta-analysis so far have not shown long-term benefit of plaque modification, but we need it in cases where we are not able to cross the lesion and we are unable to dilate the lesion with conventional methods. This study, ROTA-SHOCK, showed that IVL might be better in calcified plaque fracture in comparison to the rotational atherectomy. Various studies were conducted on IVL safety and efficacy, and they were all successful. EXIT-CALC study was a small study. It showed no difference in outcome by comparing the IVL and conventional angioplasty. This is a slide regarding the use of cutting balloon and scoring balloon, previous studies. So the AHA and ESC guidelines recommend the use of rotational atherectomy in cases where it's difficult to cross the lesion by the conventional method and heavily concentric calcified lesions. This shows the trend. So IVL has taken over all other methods in calcium plaque modification since it has come through in the clinical practice. The upfront rotational atherectomy use are using it after failure of various devices has shown that if it's used upfront, so it will reduce the procedure time and contrast. So it's usually better to plan the treatment before starting the procedure based on the available imaging. Example cases, so this was one of the 78-year-old gentlemen presented with an STEMI calcified lesion. Here I decided to go upfront straight for the rotational atherectomy using 1.5 millimeter burr. And after rotablation, I pre-dilated the lesion with 3O balloon and then delivered stent and post-dilated the stent. This is another case of right coronary artery where I took the rotablator 1.5 burr, did the rotablation, and then when I tried to cross the lesion for further pre-dilatation with the angioscalp balloon, I couldn't cross the lesion. Therefore, I decided to pre-dilate with a 2.5 semi-compliant balloon, and I could see various areas of underdilatation. So at this stage, I decided to use the IVL. I used the IVL 3.5 times 12 millimeter balloon. It was difficult to deliver it, and I used Grand Slam wire and the guide liner to support the procedure. And then after IVL delivery, I pre-dilated the artery again and then delivered the stent and was able to get optimum results. This was a 67-year-old gentleman, again, LAD disease. I can see lots of calcification and disease there. So here I decided to go with a cutting balloon. This was the non-compliant balloon, which couldn't go up. And after cutting balloon, I did IVUS to ensure the calcium fracture. I used Wolverine 2.75 10 millimeter balloon, and this was the final result. Obviously, before delivering the stent, I did further pre-dilatation with angioscalp balloon, which I think is important to do in any of the calcified cases, to pre-dilate again with scoring balloon or NC balloon before delivering the stent. So procedure tips in best practice. So always ensure balloon sizing for the scoring cutting balloon and rota burr size. These are some of the references I have given here, which is recommended to use and based on the vessel size. This is the European expert consensus on rotational atherectomy, on the burr size, the speed of the burr, and the way it should be performed. Always aim for the optimum stent expansion before delivering the stent. And after delivering the stent, it's always best to perform further imaging to make sure that optimum MSA has been achieved, which is recommended to be 5.5 millimeter square for the non-left main stem, and the parameters for the left main stem are given here. For the distal left main stem, 11.8 millimeter square, and for the ostium of the circumflex, 5.7, more than 5.7, and for the LAD ostium, more than 8.3. And it's always important to be prepared for complications in treatment of calcified coronary lesions. As discussed, there are various algorithms for decision making, but in simple, it's best to perform the imaging, and then based on that, classified as mild to moderate or severe calcification. Mild to moderate IVL would be the best choice because simpler, less complication rate, and possibly less expensive. In severe calcified lesion, the best option is to go for the upfront rotational atherectomy. So as discussed, rotational atherectomy has chances of complications in terms of coronary perforation, burr entrapment, no reflow, and slow flow, and higher contrast and fluoro time is utilized in this technique. Non-atherectomy, the downside of that could be the lesion may not be well prepared, and if not checked before delivering the stent, so there might be a stent under expansion. And the comparative complication were described in the ECLIPSE trial. For perforations for 1.8, for the orbital atherectomy, and for the balloon angioplasty was 1%. Again, these slides give the complication rate of the rotational atherectomy over a period of time since 2006 until 2016. And we can see the risk of dissection is between 2 to 7%. The risk of perforation is also 1 to 2%. And the risk of death is 0.5 to 2%. So cost-wise, atherectomy devices are expensive. Requires a specific training, and it usually have prolonged procedure time. So the conclusion is that it's best to have your strategy before starting the procedure, that whether you would like to go upfront with rotational atherectomy or orbital atherectomy or balloon-based modification of the lesion. And then after modification, it's best to recheck and further pre-dilate the stent, ideally with the scoring balloon, to ensure that the lesion is well prepared, and then deliver the stent and post-dilate well.